All right, so here we are back with chapter 42 in part 4 of Obstetrics. In this section here, we're going to talk about the delivery phase of delivering a baby, as well as some of the drugs that are acceptable to give a pregnant woman. And then we'll finish it off with beginning to kind of discuss some of the complications that we may encounter. None of the heavy stuff yet. That'll be in part 5. So we'll go ahead and get started, and let's get started with delivery. We finished off in part 3 talking about getting prepared for delivery. Now let's talk about the delivery phase. Our job in this literally is just to assist with the delivery. That's what we're there for. We're going to assist with that delivery. So when that crowning occurs, we want to place a little bit of gentle pressure on the baby's head to prevent that delivery from happening too quickly and causing any additional tearing. And then we want to make sure that we support that baby's head as it emerges, and then be ready for it to begin to turn. That baby's head's going to turn as the shoulders begin to line up. Don't attempt to force the turn. Don't try to pull the baby out or do anything like that. Remember, you're just assisting. Mom and baby are doing all the work. If there's a membrane, if that membrane's still covering the head, just go ahead and tear it with your fingers, or you can use something to cut it with. Just be very, very careful that you don't cut the baby, because remember, the baby's skin's going to be very tender, very easy to cut as well. So just use extreme caution if you have to use some sort of instrument to tear that membrane off. This is going to be so that the baby can breathe, as it continues to be born. At this point, you want to go ahead and slip a finger along the side of the head and by the neck, just to check and make sure that we don't have the cord kind of beginning trying to wrap around the neck. If we wind up with some compression of the cord, or if we've got that cord that's kind of sticking out or kind of protruding out, we want to make sure that we give that cord a little bit of room, because the baby's still relying on that cord for circulation. So if there's compression on that cord, this can cause a further lowering of the fetal heart rate and can cause some fetal distress. So try to slip that cord gently over the shoulder and the head as necessary. If it's wrapped tightly around the neck and you got no choice, you can place your clamps 2 inches apart and then cut between the clamps. But again, be very careful not to cut the baby. We do not want to cut the baby and injure the baby in any way. So you're going to have to be very, very cautious when you do this. When you do this process, with the head still supported, clear the airway by using the suction bulb syringe. So that way, once the baby is delivered and they take that first breath, they're not sucking in all that amniotic fluid. Right now is the time that you can do that, before they've taken in that first breath. So now's a good time to do it. So there's a lot going on during this phase. The baby's head comes out. It's going to be facing down. It'll start to turn as the shoulders begin to line up. We want to make sure that there's not an issue with the cord wrapping around the baby's neck or protruding. So we want to if that's the case, then we want to deal with that. We may have to cut the cord, or we may just be able to just slip it over the baby's head. And then, of course, we want to use that bulb syringe and suction the baby's nose and mouth to get any amniotic fluid that may be residing there. All right, so then gently guide the head downward, baby's head with the next contraction. That baby's head is going to kind of want to tilt downward so the upper shoulder can clear the pelvis. Just help gently guide that. Remember, we're not pulling, we're not tugging, we're not forcing anything. We're just acting as a guide, and we're not trying to prevent it from gently going downward either. It normally should go down a little bit. And once that upper shoulder is delivered, then the lower shoulder will want to start to try to emerge, and we'll need to guide the baby upward a little bit, the head upward, while we're still supporting the baby, their head and neck and shoulders. And then relatively quickly after that, the rest of the baby, the trunk and hips and legs and all that stuff will just kind of slip right out. Make sure that you hang on to that little one as they emerge, as they come out, because they get they're wet and they're very slippery. So be really careful handling them. Realize that it's very easy to drop them at this stage. So keep them very close, and very well in hand to prevent dropping them. Once they're delivered, keep them at the same level as the vaginal opening to prevent any blood from draining away from the baby. Wipe any blood and mucus from the newborn's nose and mouth with some sterile gauze, and you can use the bulb syringe again to suction the mouth and nose to clear the airway. This might actually help stimulate them to start breathing. Begin drying the newborn with sterile towels and wrap them in a dry blanket to keep them warm. Record the time of birth for the patient care report. The newborn will typically begin breathing on their own and will transition from a bluish grayish color to a much more normal baseline color in the head and the chest area. Now, then what you want to do is you want to get your at birth APGAR, 1 minute after birth APGAR, and your 5-minute APGAR scores. This APGAR score essentially evaluates a newborn's vital functions immediately after birth. There's 5 parameters to this, and they're scored from 0 to 2. They're done at 1 minute and 5 minutes after birth. So it's going to be heart rate, respiratory rate, muscle tone, reflex irritability, and color. Most newborns are going to score between a 7 and a 10. If an infant scores between a 4 and a 6, it typically means that they're going to require resuscitation to some degree. Now, we'll get into the nuts and bolts or bread and butter of the APGAR scoring a little later on in chapter 43. So it's not really highly something that's relevant right now. When we start talking about neonates in chapter 43, we'll get down a little bit deeper into the APGAR scoring. Now, then you need to cut the cord. After the baby's completely delivered and breathing well, the umbilical cord can be cut. And here's how we're going to do it. We're going to handle the cord carefully because it does tear very easily. We're going to tie or clamp the cord about 4 inches away from the baby's navel with 2 clamps 2 inches apart. And then we're going to cut the cord between the clamps. Check both ends of the cord to ensure that there's no bleeding, that our clamps are holding good. If there is bleeding at the end attached to the newborn, put another tie or another clamp on that cord to see if that's going to get the bleeding to subside. Don't remove the first clamp, leave that clamp on there, add another clamp. Once the cord is cut, wrap the baby in a blanket, and if the mom's stable, give her the baby. She may want to go ahead and try breastfeeding the baby, or she may just want to hold the baby. The placental delivery usually is going to follow about 30 minutes after the newborn is arrived on the scene. Reassure the mom while waiting for the placenta to separate naturally. Just let her know that there's another stage to this that's coming, and that it can take a little bit of time. Of course, don't pull on the umbilical cord or attempt to speed up the placental delivery in any way. Let that happen naturally. The patient will usually report that her contractions have come back again, and when this happens, the uterus rises up in the abdomen and begins to feel firm when palpated. The end of the umbilical cord protruding will lengthen, and then blood will typically gush from the vaginal opening. Instruct the patient to bear down to kind of help expel that placenta and to contract that uterus, because those uterine contractions will actually help cessate the bleeding that will follow. Once the placenta is delivered, you'll notice that the fetal side of the placenta is appears kind of a grayish, kind of shiny, smooth color, and the maternal side will look dark maroon and kind of have a rough texture to it. So that's to be expected in what that should look like. Place the placenta in a bag so that it can be taken to the hospital with you. The physician will want to further examine that. They'll want to make sure that that placenta is intact and all the pieces are there, just to make sure that there's not a piece left behind. Of course, examine the perineum for any lacerations that may need tended to. If any of those are actively bleeding, you can apply some gentle but direct pressure on those. Clean the patient as much as you can and place sanitary napkins or sanitary pads over the vaginal opening. If the patient requests to keep the placenta, note that in your transport. Some families do keep the placentas following birth. Do not wait. However, don't wait for that placenta to be delivered before beginning the moving towards transportation. So you may want to also begin transporting, and the placenta may not even be delivered until after you arrive at the hospital. Prepare the patient for transport, get them on the move. In that meantime, after the placenta has been delivered, or during the time that the placenta has been delivered, you can kind of gently massage the fundus or the more round part of the abdomen to get the uterus to continue to contract, to help kind of cessate the bleeding. If there's continued bleeding, that's the process that you're going to do. We're going to talk about that a little bit later on too. Postpartum care, of course, get a good set of vital signs and monitor the mother closely for signs of hemorrhage or shock. Don't just think everything's perfect. You're going to have to double check and make sure there's no continued active bleeding. Watch for seizure activity, respiratory difficulties, things such as that. Assess the fundus and ensure that it's firm on palpation. If needed, as I mentioned, you may need to massage that to help control some excessive postpartum hemorrhaging. Note the vaginal discharge of blood and mucus following delivery, so make sure you keep track of that. It is usually red in color for the first few days and then decreases in the amount and changes to a brownish color over several weeks. Cover the mom with blankets and maintain warmth and comfort for the ride to the hospital. So now I want to talk about a few of the pharmacological interventions that we can use for the pregnant mothers. So hepatic metabolism and renal excretion increases during pregnancy, as we've mentioned before. These can cause IV medications to pass quickly through the maternal system. Higher doses of medications may be required in some instances in order to change, because due to the change in the mother's overall volume of blood that she carries. Oral medications may take longer to work because the gastric absorption rate may be slower during pregnancy. And then there's very few medications that are actually recommended for us to use in the pre-hospital setting for the pregnant moms, just because of the risk factors associated with many of those medications. Of those, magnesium sulfate just so happens to be one of them. This one's classified as an electrolyte, and this one acts as a central nervous system depressant. In pregnancy, it is used to manage eclampsia. It may also be used in patients with preeclampsia to prevent seizures. Side effects may include drowsiness, respiratory depression, hypotension, and bradycardia, especially with a rapid administration of this drug. Always double check this drug and look at it closely to make sure it's magnesium sulfate and not morphine sulfate. Fortunately, most ambulance services keep their scheduled or their narcotics locked up in a separate area from their magnesium sulfate. But those services that don't, make sure that you're giving the right drug, because it can be easily in a hurry seen, or superimposed. You may think you're giving magnesium sulfate when you're actually giving morphine sulfate, so be very careful there. Calcium chloride is an electrolyte and serves as an antidote for mag sulfate overdose. Now, sometimes people will mention, or services may carry calcium gluconate. These drugs are somewhat interchangeable. Realize that it just really has to do with how these drugs are metabolized a little bit differently, and how how they can affect the veins that they're given in. Neither one of these are hypercritical or a reason to give or not to give one particular one over the other. They'll both work for these instances. So we'll use it as an antidote for mag sulfate. So if we somebody's given too much mag sulfate, we can use calcium chloride. Calcium gluconate does work as well. Side effects that are for either drug is going to be similar: nausea, vomiting, syncope, bradycardia, dysrhythmias may be present. It's administered via slow push, either one of them, gluconate or chloride, with repeated doses given according to protocol and, of course, according to how the patient's responding to it. Valium, of course, is a benzodiazepine that's been talked about quite extensively to this point. It is indicated for eclampsia when seizures do not respond to mag sulfate. So we may wind up have to resort to a benzodiazepine if they don't respond to mag. Side effects are going to include nausea, vomiting, respiratory depression, hypotension, and even some ancillary side effects such as headache, and some amnesia may take place as well. Benadryl is an antihistamine used to treat allergic reactions, but its sedative and antiemetic properties may also be helpful in treating some of those patients that suffer from, just really horrible motion or pregnancy sickness, morning sickness. So it may be helpful with that, but some side effects are going to include drowsiness, headache, tachycardia, and hypotension. Zofran is an antiemetic that's used to treat nausea and vomiting. It's very effective. It has that potential side effect, though, of the QT prolonging. So whenever you're giving this, it's important to make sure that you have that, they're hooked up to a heart monitor and we're monitoring, for any of those QT changes that may take place. Oxytocin is a naturally occurring hormone that triggers those uterine contractions, and it can be used to induce labor. Of course, that's not what we're going to use it for, but it can be actually very helpful in helping to control postpartum hemorrhage, and this is where we would most likely see it used in the pre-hospital setting. A lot of services don't carry this, but some do. It should only be used to manage that severe postpartum hemorrhaging after all other efforts and after all of the products of birth have been expelled. So that's essentially the only time that we're going to use it in the pre-hospital setting. Side effects of this is going to include things like nausea, vomiting, seizures, cardiac dysrhythmias, anaphylaxis, and if we give too much of it, it can actually cause uterine rupture, hypertension, and even comatose. All right, so now let's look at, and we're just going to touch on a few of these before we finish out part 4, but let's look at some of the complications of labor and as well as the pathophysiology's assessment findings and how we would manage those. We're just going to talk about maybe a handful in the last part of this section. And then when we move on to part 5, we're going to talk about a whole lot more of them. So premature rupture of the membranes. This occurs when the amniotic sac ruptures or opens more than 2 hours before labor. It's not uncommon. The sac itself may seal back up and heal itself, but more commonly, labor will typically begin within the next couple of days or 48 hours. If the pregnancy is near term, there's very little concern for alarm, but if it's not near term, there is some risk of infection and some other risks that may go along with this. So if they're not near term, they definitely need transported to the hospital. And if they are at term, they're probably going to need transported to the hospital as well. Now, preterm labor is when labor begins after the 20th week, but before the 37th week. It poses a serious threat to the unborn baby because it's not fully developed. Signs and symptoms are the same as regular labor. They'll go into regular labor. If not near term, the patient may be admitted to the hospital for medications, bed rest, and monitoring. So they may place them on medications that kind of stops the labor, or they may keep them admitted in the hospital, to try to keep that labor under control. It's all going to depend heavily on what gestational week that they're in, on how that's going to happen. Many conditions may result in fetal distress, and those things may be hypoxia, Could be that Nurgle cord, trauma, abruptio placenta, fetal developmental disabilities, and even a prolapsed cord. Any number of those things can result in fetal distress. It's really difficult for the paramedic to assess in the field and make a determination of. So we're really going to have to rely on the information that's provided to us by the patient and go off of that. The main thing that we're going to do with this is we're going to provide as much supportive care to the patient as possible and ensure that we transport rapidly to the hospital so that if there is the possibility of fetal distress, that can be managed or corrected before anything serious comes to the baby. Uterine rupture typically occurs during labor, and women that are at the greatest risk of a uterine rupture are going to include those who've had many children before and those with scarring on their uterus, such as those that have had a previous cesarean section. Signs and symptoms include a patient in active labor who is feeling weak, dizzy, and thirsty. If they've had several strong and painful contractions, but then the contractions seem to have slacked off and were replaced with a sharp tearing pain, that's going to be a big indication that something's going south. And they may have some signs of shock, such as sweating, tachycardia, decreased blood pressure. They may or may not have or show significant signs of vaginal bleeding, but look for those other abdominal signs of, internal bleeding or those kinds of things, because they may be an indication of something has went south, something terrible is going on. Of course, with these patients, we're going to treat them for shock and provide rapid transport to the hospital. All right, that's Care 4. I know it was a quick one. Care 5 is a bit longer, sorry. And it's going to cover a lot more of the complications, the abnormal deliveries, and those kinds of things that we may run into in the field. So I'll see you back at Part 5.